Okay, good morning, everyone. Very nice to see almost 40 people already joined. Very important topic, pharmacogenomics. Rarely we discuss and rarely we have any idea that what exactly it is. So today's topic will be covered by Dr. Rabiya. Dr. Rabiya has finished her MD from our department, and now she is senior resident in our department. She has taken active interest in all the departmental activities, academic as well as clinical, and she has proved that future of palliative medicine is secure in India. She has also completed pediatric palliative care program and participated in various conferences with the good track record. She has already started publishing papers, and she has got 3 papers in Indian Journal of Palliative Care. So this is Rabia, and to moderate her this thing presentation, we have Raghav. Raghav is a very brilliant faculty of our department. He's working as an assistant professor right now. She has got a lot of training experience and publication, almost already at this age 30 publications, and he was like actively interested in various activities of the department. Like whatever you do in the department, he is always ready to help, and when he helps, he is working sincerely with full concentration whatever work we do. So whatever we have done in the department is basically the activities of our residents, and Rabia and Raghav both are amongst them. Raghav has already become a faculty and Rabia is senior resident. So both, I welcome both of you, and please start your presentation so that everyone is waiting to hear what exactly is there in the pharmacogenomics of opioids. Go ahead, Rabia.
A very good morning to one and all. Thank you, Sushma ma'am, for the wonderful introduction. Today, I will be presenting opioid pharmacogenomics. I myself is Dr. Rabiya, Senior Resident in MD Palliative Medicine, AIIMS, New Delhi. Thank you, Raghav sir, for moderating my presentation. The outline of my presentation is as follows: pharmacogenomics and personalized prescription, broad pharmacokinetic and pharmacodynamic effect of pharmacogenomics. Now, what is the pharmacogenomic role of cytochrome P450 enzymes, mu opioid receptor, ABCB1, COMT, and pharmacogenomic guidelines for opioid prescription? Now let's look into a case scenario. A new mother just haven't given birth to a healthy baby. Unfortunately, the delivery has left her with debilitating postpartum pain due to the episiotomy incision. The doctor prescribes her a painkiller, which is a Tylenol, a combination of codeine and paracetamol, which really helps her, but also makes her feel drowsy, tired, and sometimes constipated. At the same time, she noticed on day 7, her baby isn't feeding very well. On day 11, it was seen that she visited a pediatrician who reassures that everything is fine and recommends her to freeze and store her excess breast milk for convenience, and she goes home relieved. On day 12, she noticed that the baby's skin was gray and his milk intake was drastically fallen. On day 13, her child doesn't wake up from the crib and was found dead. The autopsy of the child was being done. Extremely high levels of morphine was found in her son's blood, and infanticide was considered. Now, this is a true case study published in the Lancet back in 2006. So what could have been possibly happened in this case? Almost all the women who undergo normal vaginal delivery and has an episiotomy pain was being given Tylenol, which is a combination of codeine and paracetamol. And every mothers were fine, and their neonates were also breastfeeding properly. So what happened in this particular case that the neonate had a tragedy? Now let's look into the study. Lancet 2006, pharmacogenomics in a breastfed neonate of a codeine prescribed mother. Due to the episiotomy pain, I'm highlighting that the mother was prescribed a combination of codeine 30 mg and paracetamol 500 mg after birth. Initially, 2 tablets every 12 hourly was reduced to half that dose from day 2 because of somnolence and constipation. She continued the tablets for 2 weeks along with breastfeeding. Now, keeping this case scenario, now let's go ahead. What is opioid pharmacogenomics? Now, pharmacogenomics is the study of how genes will affect a person's response to drugs. It combines both the pharmacology, that is the science of drugs, and the genomics, the study of genes and their functions to develop effective, very safe medication and doses that will be tailored to a person's genetic makeup. Now, whenever a drug enters into our body, they have been metabolized and structurally modified with various enzymes which either activated or deactivate these medications. And the most well-known family of drug metabolizing enzymes are the CYP450 enzymes. Now, what determines our response to various medication? First is the genetic variation in metabolism. Second is the genetic variation in the receptors and the transporters present in our body. What are the comorbid diseases you are suffering from? Do you have any CLD, CKD? Whether you're in the old age group or in the young age group, whether you're a male or a female, now what is your diet intake? What are the environmental factors? And lastly, the drug-drug interactions. So broadly, you can classify genetic factors influencing analgesic response and side effect profile broadly into 2 categories. That is the pharmacokinetic factors and the pharmacodynamic factors. Now, in pharmacokinetic factors, you have the drug metabolizing enzymes like the CYP2D6, all the CYP enzymes. Drug elimination, you have the UGT2B7. Drug transporters, example, you have the ABCB1 or MDRR1. Drug receptors, you have the OPRM1. That is mu opioid-like receptors, and signal transduction, you have the COMT. So let's look briefly into what is the pharmacokinetics of opioid pharmacogenomics enzymes. Now, cytochrome P450 enzyme is the most widely studied enzyme in genomics. There are over 50 different isoenzymes of CYP450 enzymes, 7 of which are involved in metabolizing over 80% of the medications. So what is the CYP2C9 or CYP2D6 refer to? CYP represents the root symbol of cytochrome P450. 2 is the subfamily, C is the subfamily, and 9 is the gene identifier. So what is the cytochrome P450? They are the microsomal isoenzyme complex, which are located in the smooth and the rough endoplasmic reticulum and the nuclear membrane. It is present in several tissue, but if you ask me where is the highest concentration, is in the liver. The prosthetic group, heme, common to all the isoenzymes. Apoprotein, variable among isoenzymes, contains xenobiotic binding sites. They catalyze mainly oxidation reaction with high substrate versatility. Now, CYP2D6 and CYP3A4 are the most important isoenzymes for xenobiotic metabolism, almost 50%. Now, several factors interfere with its expression and activity, like the endogenous factors and the exogenous factors. So this is a schematic diagram to highlight that there are multiple types of or various types of isoenzymes of CYP450 superfamily. Now, according to the CYP2D6, which has been most widely studied isoenzyme in the CYP450 superfamily, everyone can be classified into ultra-rapid metabolizers, either extensive metabolizers, intermediate metabolizers, or poor metabolizers. Now let's look into each case scenario. Now, who are ultra-rapid metabolizers? More than 2 active gene copies on the same allele or increased expression of a single gene. You can see that in some of the population, they can have gene duplication or gene multi-duplication. Now, what does it refer to? Now, if you give a prodrug like a codeine, because they are ultra-rapid metabolizers, more active component is being formed. When more active component like morphine is being formed, the adverse reactions and the side effects are more. So the adverse reactions after codeine and tramadol treatment is more in ultra-rapid metabolizers. Now, if you look into extensive metabolizers, majority of the populations are extensive metabolizers. They have 2 functional alleles. They have an ordinary response and normal metabolism. Now, looking into the intermediate metabolizers, 1 defective allele or 2 partially defective alleles. In this case, they have reduced response to tamoxifen and to analgesic treatment. So this is very common scenario. Some of the people are responding well to the morphine in lower doses, and some requires a higher dose. So there could be a genetic variation of the CYP2D6 enzymes in their body. Or it can be a poor metabolizers. That means they have two defective alleles and they have reduced response to analgesics and tamoxifen. Reduced response to analgesics, they have multiple OPD visits, they have poor metabolizers. So we have to keep in mind that there can be multiple types of metabolizers of CYP2D6 in our day-to-day practice. So now I'll give you some examples. In poor metabolizers, if you give codeine or tramadol, they have poor analgesic efficacy. The standard drugs, there is reduced elimination and increased toxicity risk. If it's a prodrug like codeine, there is decreased effectiveness and decreased activation. Similarly, if you give a drug to an intermediate metabolizer, there can be increased drug to gene and drug to drug interaction risk and possible increased toxicity risk. Normal metabolizer, normal response, there is no need to worry. But in rapid or ultra rapid metabolizers, you have to be extra cautious, because if you give a standard drug in these cases, there is reduced effectiveness and increased elimination. So the patient might require more dose. But if it's a prodrug like codeine, which has been converted to an active metabolite like morphine, they have increased activation and increased toxicity risk. So now you can see that in this diagram, it clearly highlights that CYP2D6 is the major isoenzyme responsible for metabolizing opioids. In codeine, it is being metabolized by the CYP2D6, fentanyl by CYP3A4, hydrocodone CYP2D6-3A4, methadone again CYP2D6-3A4, 2C8, 2C9, 2C19, 2B6 and A1A2. Oxycodone CYP2D6, CYP3A4, and tramadol CYP2D6. So from this table, it is clearly evident that the majority of the opioids are being metabolized by CYP2D6 and CYP3A4. Now, there are some opioids like the hydromorphone, morphine, oxymorphone, and tapentadol. They are not metabolized by CYP450 enzymes. They undergo phase 2 metabolism, like the glucuronidation via the UGT2B7. Rest all the codeine, hydrocodone, tramadol, oxycodone, fentanyl, and methadone undergoes first pass metabolism, that is with the help of CYP2D6 or CYP3A4. Now, role of CYP2D6 in the metabolism of codeine, tramadol, and hydrocodone. So if you give a codeine, which is a prodrug, it is metabolized with the help of CYP2D6 to an active metabolite, that is morphine, which is further inactivated with the help of UGT2B7. Similarly, tramadol, if you give it, it is metabolized in CYP2D6 and CYP3A4 into active component do-O-dismethyl tramadol, and hydrocodone, after metabolized by CYP2D6, they get converted to active metabolite hydromorphone, UGT2B7 inactive metabolite. So this diagram, I would like to emphasize that CYP2D6 enzyme converts codeine, tramadol, and hydrocodone to their active metabolites. And CYP2D6 ultra-rapid metabolizers are at an increased risk for side effects from these drugs, whereas CYP2D6 poor metabolizers are at a risk for inadequate pain control. So if you give codeine to a patient, CYP2D6, like in this case scenario, lower than normal, she was a poor metabolizer. If it was normal, she was extensive and intermediate metabolizer. But if she was an ultra-rapid metabolizer, there is always an increased risk that she want more concentration of morphine in her blood. So that was about enzymes. Now there can be variations in various other transporters in our body. For example, the ABCB1, that is the adenosine triphosphate binding cassette, subfamily member 1, also known as P-glycoprotein or multi-drug resistance protein. Now, ABCB1 transporters are present in numerous locations, the GIT, liver, kidney, blood-brain barrier, and they facilitate the absorption, the distribution, and elimination of the medication, including opioids such as morphine and fentanyl, as well as their metabolites. Any impairment of these transporters can lead to increased bioavailability of oral medication, decreased renal excretion, increased central nervous concentration. The transport of opioids to the blood-brain barrier may be affected by variation in the ABCB1 transporters. So this is a schematic diagram showing that the ABCB1 is responsible for absorption, distribution, as well as the elimination of these opioids. Now let's look into the morphine metabolism, which we are using in our day-to-day practice. So morphine undergoes metabolized by CYP3A4 is converted to normorphin and hydromorphone. And the major metabolic pathway, 90% is converted to morphin 3 glucuronide, active metabolite, which has no analgesic effect, neuroexcitatory effects, cannot cross the blood-brain barrier. Around 10% is responsible for the potent analgesic properties and can cross the blood-brain barrier is the morphin 6 glucuronide, which is the active metabolite. So whenever you're giving morphine, there can be genetic variation at various levels. It can be UDP, UGT1A9, UGT2B7, or it can be in the cytochrome P450. Or it can be any transporters like the ABCB1, ABCC2, ABCC3, SLCO1B1. So this schematic diagram shows that while a few of the patients will respond to a lower dose of morphine, few of them respond to a higher dose of morphine, some of them have adverse drug reactions, some of them are tolerable. So these can be a multiple variation at their genetic levels. Now we have completed the enzymes, we have completed the transporters. Now it can be a difference in the receptors. We know that opioid receptors, mu receptors, which are present in the peripheral inflammation, pre and post synaptic neurons in the spinal cord, periaqueductal gray, nucleus raphe magnus, thalamus, cortex, or it can be kappa receptors, which are present in the spinal cord, supraspinal, hypothalamus, or it can be the delta receptors, olfactory centers, motor integration areas in the cortex, limited distribution in the nociception areas, or the opioid-like receptor that is in the spinal cord. So there can be multiple genetic variation at every level with these receptors of the mu, kappa, delta receptors, or the orphan, ORL1 opioid-like receptor. Now, this is a study published in 2011 in Future Medicine S. Kasai, Pharmacogenomics of the Human Mu Opioid Receptor. In this study, it was concluded that the mu opioid receptor is a primary target for opioid analgesia, including morphine, fentanyl, and methadone. Many genetic variations have been seen in the mu opioid receptor level. Like the most commonly seen is the A11HG polymorphism genotype. It is associated with substance abuse and susceptibility to various disorders. The IVS1A2-157-3G, IVS1T17286C, TAA, these all are polymorphisms and opioid effects and substance dependence. Now, further studies are needed to elucidate more OPRM1 polymorphisms. So there can be various types of different polymorphism at the level of the receptors. Now, it can be a difference in the signal transduction, that is the enzymes again. Human catecholamine COMT polymorphism. So this diagram clearly shows that there can be allele frequency of 1 to 10%, more than 10%. So you can see multiple variations present in different population. So what is this COMT enzyme? So it will convert the tyrosine in our body to 3,4-dihydroxyphenylalanine or 3-O-methyl-dopa, dopamine to norepinephrine and epinephrine. Now, I have put this slide to emphasize that the patients who have human COMT polymorphism and GG allele variation, they require more morphine for the same analgesic response or for the adequate analgesic response because of this particular mechanism where they convert it to no-laudonosine, 6-O-methyl no-laudonosaline, and 3-hydroxy and methyl co-clarine and raticuline. So this mechanism, they might require more morphine requirement than the normal population. Now let's look into the case study, which I have described in my first slide. In April 2005, a full-term healthy male infant was delivered vaginally, showed intermittent periods of difficulty in breastfeeding and lethargy on day 7. On day 12, however, he had gray skin and his milk intake had fallen. He was found dead on day 30. Looking back to the history, she had an episiotomy pain and she was prescribed a combination of codeine, 30 mg and paracetamol 500 mg after birth. Initially, she took 2 tablets every 12 hourly and reduced to half that dose from day 2. Now, because of somnolence and constipation, she continued the tablets for 2 weeks. So what could possibly be the cause of death of the neonate in this case? Now place the pharmacogenomics. When we did a genotype analysis, it was found that she was a ultra-rapid metabolizer, meaning that she had a heterozygous of CYP2D62 allele or a gene duplication classified as ultra-rapid metabolizer. So what happened here? You gave codeine, which is a prodrug. Because she was an ultra-rapid metabolizer, she broke down the codeine to an active metabolite, that is morphine, and then morphine concentration was very high. She was recommended to store her breast milk, which actually had a morphine concentration more than 70 ng, and while feeding the baby went into opioid toxicity. High levels of morphine were found in her frozen breast milk. A year later, this was been reported. The FDA added a warning label on codeine use during breastfeeding because we do not know exactly who are ultra-rapid metabolizers, who are poor metabolizers, or who are intermediate or extensive metabolizers. So in 2007, it was being emphasized by the FDA, the risk of infant exposure to codeine and morphine through breast milk should be weighed against the benefits of breastfeeding for both the mother and the baby. A caution was been put out should be exercised when codeine is administered to a nursing woman. If a codeine-containing product is selected at the lowest dose, should be prescribed for a shortest period of time to achieve the desired clinical effect. This was in 2007. But they re-emphasized on 2017, so that we are now adding a strengthening warning to the mothers that breastfeeding is not recommended when taking codeine or tramadol medicines due to risk of serious adverse reaction in breastfed infants. These can include excessive sleepiness, difficulty breastfeeding, or serious breathing problem that could result in death. So now everyone would be thinking that is codeine a bad drug? Because most of the patients in the US after delivery or after episiotomy pain, they are being prescribed Tylenol. So is it a bad drug? Absolutely not. It depends on the person. Whether you are a slow metabolizer, whether you are an intermediate metabolizer, normal metabolizer, or an ultra-rapid metabolizer. Unfortunately, we just don't know who the right people are unless we do genetic testing, which is still quite expensive and has implication on privacy and ethical issues. But surely this tragedy could have been avoided if the doctors knew that the mother was an ultra-rapid metabolizer, so she would not be prescribed codeine. Now, this is not about only codeine. Almost all the drugs are metabolized by a combination of the CYP450 superfamily and phase 2 enzyme like the TM, TPMT, and UGT. Many of these enzymes have genetic variation that change their function, altering the effectiveness and the toxicity of the drug. Now, genetic variation are the major cause of adverse drug reactions, which are a huge burden on the healthcare system. Now, what is the solution? Now comes the personalized prescription or the precision medicine. Now, how is it different from traditional medicine or the stratified medicine? Now, in traditional medicine, you can see a group of people are being given a drug, a therapy, and some of them might have adverse effects, some might benefit from that, and some might not benefit from that. That is traditional medicine. Now, what is stratified medicine? The patients are grouped according to the disease subtypes, the risk profiles, the demographic, whether they are Caucasians, whether they are Asians, they are Chinese, socioeconomic factors. Now, what are the clinical features of the pain, biomarkers, and molecular subpopulation? And then they are given a therapy. Patient groups benefit from more targeted treatment. Now, what is precision medicine, which I am highlighting today? Individual patient level. You're looking into the genomics and the omics of the patient. Lifestyle of the patient. What is her preferences? What is the health history? What are the medical records? What is the compliance and exogenous factors? So you're giving a therapy. Each patient benefits from individualized treatment. So I would like to highlight that each person gets an individualized treatment. We are not grouping them into any subgroups. Now, that is the idea behind precision medicine research enables development and delivery of the right patient intervention. So what is the goals of precision medicine? First of all is prevention. That is early detection of patients at risk, improve preventive measure at the individual level or collective level. Second is the diagnosis. Accurate disease diagnosis enabling individualized treatment strategy plan. What is the treatment? Improved outcome through targeted treatment and reduced side effects. So this is the future. Impact of genetic variants on medication response, how to give the right drug at the right dose for the right person is the major goal in the era of precision medicine or personalized prescription. So how can you do a pharmacogenomic testing cycle? In the US, the doctor has a genetic panel. The physician orders a pharmacogenetic test. A sampling of the biomaterial has been done. They've been sent to the laboratory, analysis data and generate the report, review test results with the patient, and development of personal treatment strategy and dosage. So there are various engineering precision medicine technologies like the genome-guided medicine, genome sequencing, actionable gene identification, pharmacogenomics, and electronic medical boards, diagnostic like biomarker discovery, co-clinical trials, imaging, radiomimics, and radiogenomics. The therapeutics also like CRISPR, zinc finger nucleases, chimeric antigen receptor T cells, and checkpoint inhibition. The devices used in pharmacogenomics like circulating tumor DNA, RNA, single cell biopsy analysis, and drug screening. Now, use of pharmacogenetic to help inform your prescribing decision. So traditional treatment, it's a trial and error method. Some may benefit, some may not benefit. You are giving the same prescription at the standard dose. But in precision medicine, using pharmacogenetics, you're giving a person normal dose. Some of the patient can give, if there are poor metabolizers, lower dose, or ultra rapid metabolizer, higher dose, or alternative. It's a personalized drug choice and personalized dosing according to the metabolization variabilities. So this is a study which is published in 2015, GC Bell, Clinical Implication of Opioid Pharmacogenomics in Patient with Cancer. 2,166 records identified through database searching. 2,166 records were screened. 173 articles included in this review, which had opioid of codeine, fentanyl, methadone, morphine, oxycodone, and tramadol. And the genes involved by CYP2D6, CYP2D6, CYP3A4, CYP2C19, UGT2B7, ABCB1, OPRM1, COMT, and DRD2. It was concluded that genotyping patient may allow the healthcare professional to better predict the patient response to pain and thus personalize the pain treatment. Now, this is another study by Ashley Singh, the pharmacogenetics of opioid treatment for pain management. It concluded that CYP452D6, CYP3A4, CYP3A5, COMT, ABCB1, OPRM1, and OPRD1 are all important genes involved in opioid drug response, the side effect profile, and the risk of dependence. These are very important genetic factors that should be included in potential opioid prescription test for pain management. Now, what is the guidelines of pharmacogenomic-based prescription? So initially, you do a genetic screening. For chronic pain, precision medicine, different drug regimens were formulated according to different genotypes. So you have the CYP2D6 phenotype. You can either have a poor metabolizer or intermediate metabolizer. Increased risk for reduced analgesic response to opioids. Ultra-rapid metabolizer, increased risk for toxicity. And normal metabolizer, you can give a usual care. If they are poor metabolizers or ultra-rapid metabolizers or intermediate metabolizers, you can change the opioid therapy to morphine, hydromorphone, fentanyl, or other analgesic without dependence on the CYP2D6 pathway. Monitoring the efficacy of chronic pain treatment, you have the OPRM1 and COMT genotyping are applied in clinical practice to monitor analgesic security profile and to improve patients' management. So where are we today? The most extensively learned or studied polymorphism in the gene is CYP2D6. The opioids with polymorphism dependent effect is the codeine and tramadol. Individualized treatment is available today. We know the effect and the guidelines are available in the Clinical Pharmacogenetics Implementation Consortium guidelines. The second gene that is widely studied is the mu opioid-like receptor for the morphine. Evidence is suggesting clinical adoption, but there is lack of peer-reviewed guidelines. And the CYP2D6 and OPRM1 for oxycodone, hydrocodone, and fentanyl have very weak evidences and no guidelines further research needed. So you have two genes which have been extensively studied about codeine, tramadol, morphine. Now let's look into the guidelines. So this is a guideline which is even published. I will be going through it briefly. So CPIC recommendation of codeine, if it is an ultra rapid metabolizer, you have to avoid codeine due to increased risk of adverse effect. If it is a normal metabolizer or an intermediate metabolizer, you can use codeine according to the patient's age and weight. Effect on codeine, codeine is converted to its active metabolite morphine at an expected rate. Now, if the patient is a poor metabolizer, avoid codeine due to diminished analgesia. Or if the patient is indeterminate metabolizer, no recommendation, effect of codeine is unknown. Similarly, the CPIC recommendation of tramadol, again, if it is an ultra rapid metabolizer, avoid tramadol. Normal metabolizer, intermediate metabolizer, you can use tramadol according to the patient's age and weight. Or dismethyl tramadol is converted at an expected rate. But if it's a poor metabolizer, avoid tramadol due to diminished analgesia. Indeterminate metabolism, there is no recommendation as of now. Similarly, hydrocodone. Ultra-rapid metabolizer, there is no recommendation. Evidence on pharmacokinetic effects, increase in hydromorphone in clinical effects, and increased risk of adverse reaction is limited. Normal metabolizer, you can use hydromorphone according to the patient's age and weight. Intermediate, same. Poor metabolizer, again, you can use hydromorphone according to the patient's age and weight. Indeterminate metabolizer, there is no recommendation. Now, there are some special cases of specialty patient population. In geriatric patients, older patient may be at a higher risk of falls and fractures secondary to oversedation. So consider starting acetaminophen and lower dose opioids. In the presence of CYP2D6 ultra rapid or poor metabolism, morphine may be effective opioid alternative. In pediatrics, use of codeine and tramadol is contraindicated in patients less than 12 years. Coming to pregnant women, again, consider tapering opioids because of the risk of withdrawal for both the mother and the fetus. Breastfeeding women, again, use of codeine and tramadol should be avoided. Renal insufficiency and hepatic insufficiency, avoid all these drugs which have been mentioned in the table. Avoid hydromorphone, ER, meperidine, tramadol, codeine, tapentadol. You can use methadone, hydromorphone, oxycodone, oxymorphone, morphine, and tramadol with caution. Hepatic insufficiency, you can use hydromorphone, oxycodone, morphine, tramadol with caution. In the presence of CYP2D6 interaction, consider starting fentanyl. Use hydromorphine, morphine, and buprenorphine with caution. So fentanyl is a relatively safer drug. So this is a diagram. It shows that the Clinical Pharmacogenetic Implementation Consortium is an international consortium of individual volunteers and a small dedicated staff who are interested in the field of pharmacogenetic testing for patient care. The CPIC started as a shared project between GKB and Pharmacogenomic Research Network in 2009. The CPIC guidelines are indexed in PubMed as clinical guidelines endorsed by ASHP and ASCPT and referred in Clinic Gen and Pharm GKB. Now, pharmacogenomic considerations in opioid analgesia. Now, translating pharmacogenetics to the clinical practice has been particularly challenging due to the complexity of multifactorial phenotypes. As I've said, that there can be differences in the enzymes, the transduction, the transporters, the signal transduction enzymes, and overall the nature of pain perception and response to analgesia. Every individual is different from each other. The clinical relevance of CYP2D6 genotyping to predict analgesic outcome is still unknown. The two extremes in CYP2D6 genotype, that is the ultra-rapid metabolizer or the poor metabolism, seem to predict the pain response and adverse effect. The level of evidence linking the genetic variability of CYP2D6 and CYP3A4 to oxycodone response and phenotype is very strong. However, there is no randomized clinical trial on the benefits of genetic testing prior to any oxycodone therapy. He concluded that the analgesic response to morphine based on pharmacogenomic testing is more complex as it depends on the pain modality, the potential for repeated nauseous stimuli, the opioid which has been prescribed, and even the route of administration. Now, this is a study published in 2010, Paul J. Janardo, Pharmacogenomic Consideration in the Opioid Management of Pain. It said that the genetic identification of the known variant alleles that affect the pharmacokinetics or the pharmacodynamics of medication used for pain management can enable physicians to select an appropriate analgesic dose and dosing regimen for an individual patient instead of empirically selecting a dose escalation. So what are the anticipated benefits of genomics? So you have a genetic paternity test, you have genetic compatibility test, genetic ancestry test, genetic fingerprinting, genetic disease risk, and then comes the personalized medicine. So what is the benefits of all these genomics? Earlier detection of genetic predisposition, improved diagnostic accuracy and speed. You can do gene therapies, like the medical oncologists are targeting each genes or the each alleles. That is, gene therapies can be given. Decrease in healthcare cost. You are not giving an empirical treatment for a person. You are individualizing the treatment to a particular patient. Personalized treatment plans and rational drug design. So this is a summary which will put everything together. In Magarbe et al. In 2021, reviewed that pharmacogenetics to advance precision medicine for opioids. Optimized opioid therapy remains very unsolved. The risk of accidental opioid overdosing is increasing, and the opioid crisis in the US is a big problem. Pharmacogenetic-based evidence are reviewed to advance opioid prescribing and dosing recommendation. So if you start a precision medicine or a personalized prescription, the opioid crisis or the opioid toxicity, opioid risk factors, opioid adverse effects, everything can be minimized. The method in this study is the systemic literature search using PRISMA guideline. Clinical studies were included if they examined the association between the genetic variants and opioids. 173 studies were included on 6 opioids, that is the codeine, tramadol, oxycodone, methadone, fentanyl, and morphine. They looked into the metabolism of these drugs. Now, what is the response? How is it being transported? And what is the adverse drug reaction or the toxicity? The results were CYP2D6 genotype. If they are poor metabolizers, meaning that they have very less active metabolite, avoid codeine or tramadol. If they are intermediate metabolizers, monitor response to codeine and tramadol. If they are ultra rapid metabolizers, again, avoid codeine or tramadol because their active metabolite is more and they can have adverse drug reactions. OPRM1A118G SNP, that is single nucleotide polymorphisms, is very common. 10% increase in morphine dose for G allele carriers. As I said, the COMT polymorphism can also lead to 10% increase in morphine dose for G allele carriers. So the conclusion was there is an emerging evidence of clinical relevance of CYP2D6 and to a lesser extent, OPR, that is mu opioid-like receptor polymorphism in personalized drug dosing, opioid drug dosing. So I would like to conclude that advances in the field of pharmacogenomics have resulted in discovery of single nucleotide polymorphism, which are associated with opioid dose variability. These polymorphisms are found in various areas relevant to pain perception, including the nociceptive and anti-nociceptive pathway, drug receptors, the enzymes, and the drug efflux molecules. Now, in-depth knowledge of single nucleotide polymorphism can help clinician to address the inter-individual variability in opioid dosing and requirement. Genetic markers can help to design tools accurately to predict the analgesic dose of opioids. So in the US, from 2009, they have been practicing this, but in India, we are still in the earlier stages of genetic variation studies. We are using it in the medical oncology. We are specifying one particular target and giving a targeted therapy. But I think it's high time that we have to, as pain physicians, we should also go and evaluate this personalized medicine, that is personal genomics, pharmacogenetics, and giving the right opioid dose to the right person at the right dose. Thank you.
It's too good, Rabiya. Excellent presentation. Excellent.
Thank you.
Raghav, can you summarize, and then we will have there are question answers. So please take up question answer also.
Sure, ma'am. So thank you, Rabiya. It was an excellent presentation. And as Rabiya has emphasized very clearly that in today's era, till now in our undergraduate and postgraduate curriculum, we have always focused upon pharmacokinetics and pharmacodynamics. But now we should think forward in the direction of pharmacogenomics also, which is the combination of pharmacy and genetics. Another important point in summary I would like to mention is that the metabolism of the drugs, that it can be a normal metabolism, it can be a poor metabolism, or it can be ultra rapid metabolism. So we have to always take into consideration that many patients, we sometimes feel that we have given an adequate dose, but still the patient is having pain. So at the back of our mind, we have to keep in mind that the patient may not be adequately metabolizing the drug. It can lead to under effect, as well as at the same point in time, it can lead to over effect of the drug. So that point has to be remembered. And another thing is the coming era of personalized medicine, that at compared to traditional medicine where we have always focused upon the history and the examination findings, now we should also take into consideration that if we have the facility and if we can go for the genetic testing, then we should see for that and accordingly prescribe the medications to the patient. So clinical implications of this whole seminar was very important, that apart from the pharmacokinetics and the dynamics, the pharmacogenomics is equally important, and that is why the drugs either may have side effects or it may not be adequate for the patient. So thank you.
So
We can
can you
take up
take
the
up the
question.
questions? There are questions in the
Sure, ma'am.
chat box.
So Dr. Rajesh sir has asked one question. The first question is that percentage transfer of morphine, codeine, and tramadol from the breast milk to the neonates. So thank you, sir, for that question. So it is approximately in the range of 1.5 to 3% of all the three drugs, with morphine being the highest, that is approximately 3%. Tramadol is approximately 2.25%, and codeine is approximately 1.2%. So this is the percentage transfer of these drugs from the breast milk to the neonate.
Next
This,
question.
yeah, second question by Preeti ma'am. It's a wonderful presentation. Please let me know how to use this in the OPD based practice. Ma'am, as Rabia mentioned at the end, that in India we are still in the nascent phase for the genetic testing because of the cost implications. So as of now on OPD basis, we are not doing the genetic testing in India. But yes, in future, based upon a lot of prospective studies, because majority of the data still is from the case control studies, case reports, and there are very few prospective studies. So based upon the research and development, a lot of pharmaceutical industries are showing their interest, and eventually it will come into the OPD clinical practice also. Any other questions, ma'am? As of now,
No, there are questions. Where is
uh,
genetic testing available in India currently?
So as of now, what I had studied regarding this in Bombay, there are few places which are studying this. Angtok, there is a company, pharmaceutical company, which is doing this. But I'll have to look more regarding that, because there are very few places who are actually doing the genetic testing regarding, especially for the opioids.
Dr. Stanley is asking whether the route of administration affect pharmacogenomics.
Uh, Route of administration. Uh,
It's
Pharmacogenomics
not clear. It's not clear,
not
Dr.
very clear.
Stanley. It's still not
Not
clear.
very clear. Not
Because
very clear.
ultimately it is going to get absorbed whatever route you are using. So
Yeah.
I don't think that there is.
No,
You want to say something?
it was mentioned in the slide. That's what I was, it was in the last slide, last but one slide. So it was interesting for me, because we do use the subacute route quite extensively in the home care situation. So I just wanted, and also from a very practical point of view, perhaps certain drugs like codeine and tramadol, we must be extra careful, but otherwise we can start with a lower dose, and within 24, 48 hours, close monitoring, we can come to an idea. We can get an idea whether it's being metabolized rapidly or, slow metabolized. And therefore, we can gauge how to proceed further, because this kind of testing is still a very far kind of thing for general application in India. So thank you.
True.
Excellent lecture. Thank you.
Thank you, sir. Thank you, sir, for the feedback.
Any comments from anyone? Before we close, we have time. Anyone wants to say anything? Please open your mic and say. Dr. Jennifer, do you want to say? Dr. Kalpana, Dr. Jennifer? Anyone? No?
No comments, ma'am. I think Dr. Stanley's suggestion is a good one. while we still don't have the luxury of doing these testings, going by clinically, if somebody expresses more side effects or toxicity, then to take it seriously and immediately come down on the dose, and that to go by clinically is important. Thanks.
Very good. So, Dr. Jennifer, thank you very much. Thank you, Dr. Stanley and Jennifer, and thank you, Rabia, for wonderful presentation. I'm because this presentation is really definitely must have been thought provoking for everyone. Shrikant, you want to say something? I can see your comment.
No, madam. Actually, I guess Mahe Manipal, Dr. Naveen Salins is doing some studies on pharmacogenomics because he submitted a project. So, not sure what the progress is. But sir is doing some study on pharmacogenomics of morphine, is what I knew 2 years back. But we don't know of its progress yet. That's what I wanted to say, that Mahe is working on that.
Yeah. Thank you, Shrikant. Thank you very much. So, thank you, Raghav and Rabia, and see you everyone in next week. And next week there will be a very, very important topic, that is topical use of medications. So this is again another very important topic, topical agents in palliative care, used in palliative care. So please attend at 6:30 sharp. Before 6:30 you should join, so that you will be able to hear a lot of things, because if you miss initial few slides, it is difficult to concentrate and it's difficult to understand. So thank you, Rabia, and thank you, Raghav, and thank you everyone for joining, and see you next week, Monday at 6:30.